Thank you so much. I really do appreciate getting a half hour, particularly early in the meeting, and thanks to Sue and Gustavo and Karen Scott. And before I begin, I think I'd be remiss if I didn't acknowledge two elephants in the room here today. First, we are meeting at a very unusual time in the history of our nation here in Washington, D.C. We're poised between two administrations, and I think we all feel enormous uncertainty about the future, and certainly more so for you all who are public servants who work in the federal government. So I have given a special thanks to our ex officios who are here, who are dealing with enormous uncertainty. So that's one elephant in the room that feels quite disconcerting to me, and I think probably to many of us, but that seems worth naming. The next elephant in the room is this one, that ME/CFS is a public health crisis. I keep the photo of this young woman in front of me on my desk every day. She's got a feeding tube. She's not the sickest of the sick, but she is quite sick. And we all know the statistics about the difficulties of ME/CFS patients. And so when I stand back and look at CFSAC, because I feel honored to be part of CFSAC, and yet when we look at this, I have to say, and I say this without criticism, merely stating a fact. We meet twice a year. We work very hard. Sick patients, smart, capable, knowledgeable people work very hard to put forward recommendations that then go back to the Secretary of HHS. Would anyone here care to take a guess at what percent of the recommendations that have been put forward to the Secretary in the 3 years, 2014, 2016, 2015, and 2016, over the 3-year period, what percent of those recommendations from this esteemed body have been enabled, have been implemented? Anyone want to take a shot? Well, I'll tell you, I think we all know it's pretty low. It's 7%. So as I prepare for these meetings, I hold this duality in my head of recognizing that CFSAC is the most critical entity in the nation, which has the resources to help solve this disease. And yet our failure rate is 93%. Now, I don't say that to be critical. I'm a member of it. If I'm being critical, I'm criticizing myself. But I think it is worth noting that this is a public health crisis, and the structure that we have used time and time again for the roughly 15 years that this body has existed is simply failing. And I think it's worth noted. It is a public health crisis, and it's a public health crisis on the order of that the AIDS was a public health crisis two and a half decades ago. Arguably, this health crisis does more damage to our citizens than the Zika health crisis. So periodically health crises arise, they get extraordinary attention and significant funding, and ME/CFS is one of those today. But what's the difference? Unfortunately, ME/CFS is like the frog in the boiling pot, in which the temperature has risen slowly, and we lack any one moment, a sudden awareness of the shock of a new terror, and therefore we lack the appropriate urgency. There are roughly 250,000 Americans who are on, we know this is a spectrum disorder, from really people who exist in kind of a living death. They're so sensitive to light and sound that they cover their ears and their eyes. They can't communicate. They're fed through a feeding tube like this young woman. So even sort of moving a little bit on the spectrum of people who are really severely debilitated, cannot live their beds and live in pain. We estimate that it's roughly 250,000 people. That's the severe folks. So let me just ask you, that is the entire population of, say, Toledo, Ohio. That is the entire population of St. Petersburg, Florida. And I ask you, what would the response of the federal government be? What sense of urgency would all of us in this room feel if suddenly it were clear that the entire population of Toledo, Ohio had been struck by a disease that destroyed the joy and and vibrancy and spirit of the lives that they were born to live. I try to imagine the uproar, and that's the appropriate uproar. That's the appropriate fear, because as we all know here, anyone could hit ME/CFS. Folks who are walking around, oblivious to this, which is the vast majority of our citizenry, really don't understand the fear that is appropriate to this public health crisis. So, they're often used to hearing chronic fatigue syndrome. So many people still think of it as a joke. It's a joke. We know it's not a joke. We know it's a widespread national health crisis in which at least 1 million of our brothers and sisters suffer, and they suffer mightily. So then I come back to, I try to be a problem solver. So what do we do? And, every person here is a person of goodwill, a person who cares, but we ain't getting it done. And I say that with sorrow. 93% of our recommendations are not acted upon. If any other organization failed so miserably, frankly, it would cease to exist. And I bet there's not a person in this room who hasn't said, oh my God, am I going to keep doing this? And the reason we keep doing it is because we in the patient community are desperate. We are desperate. And we know that right is on our side. We know that we are right in requiring our federal government to take care of the needs of those who suffer. So let me put forward one idea. So there's two elephants in the room, right? We've got this really disoriented transition occurring in our federal government. It's a time of great uncertainty, in which many of you who toil on our behalf really must be struggling. I really can't imagine. So amidst all that uncertainty, one thing is very certain. This is a public health crisis. So is this a moment, is this indeed, as counterintuitive as it may sound, an opportunity for us to hang on to one area of the responsibilities of the federal government? Every agency that's here is because they have a responsibility to serve patients. This is certain. Is this a moment we can move forward in that way? So I ask that of you. And I would say this, we can do this. In fact, we are the only body in the country that has the prerogative, the duty, and the resources to make significant inroads to this public health crisis. I mean, what other entity in our country has all the critically important pieces assembled together to genuinely affect significant change for the patients who suffer from ME/CFS? Literally. Is there any other? We all know the answer. We are it. We are the folks who have the power and the responsibility to work on it. So one of the reasons I was very pleased to speak at the beginning of the meeting today was that I wanted to make this point. I hope to jolt us and to work at ways to increase the effectiveness of this body to which we are all committed. So I had hoped, frankly, that the slides to follow here would be seen by you all ex officios before. It is not my nature and because some of them are put forward some pretty pointed requests of the agencies, and it's not my nature to blindside people, and I had assumed that you would see this before today, but such as it is, here they are. So one of the rules in my life is never to criticize something without also putting forward and committing to a solution. So the remainder of my slides attempt to do that. With ME/CFS, I can see a path forward. It requires a different and new level of commitment from both those of us who serve as volunteers on CFSAC and from the ex officios. The remainder of my presentation is an agency by agency discussion of ideas that could move this disease forward. So again, while so many things are insecure and uncertain about our lives here in Washington, this is sure. This is a dire public health problem that must be addressed. Part of the proposals that you'll see in my slides to follow are really procedural, because this body, when a body is failing, frankly, and I say that with no joy, it often is because the underlying processes and assumptions about how we will work together, simply are not in alignment with our objectives. For instance, meeting really only twice a year, this routine we go through where we work so hard, put forward recommendations, wait for some kind of response, and the response is usually no, and for lots of reasons that are well explained, and then we wait another 6 months and we repeat, and the forward progress there is some, and I do applaud the work that has been done by particularly Vicki at NIH, and there is indeed good work being done, but it is abysmally slow. And I would submit that the process by which this agency works, this organization works, is really doomed to be slow. So let me move to the next slide if I can. I think here is more about ME/CFS. Why does it continue to be a public health crisis? And a key factor is there's no central federal leadership and no central federal coordinating plan for this disease. And what's frustrating is that we know that it's been done for other diseases. Autism was a disease that was in the similar straits that we're in now, 20, 15 years ago. And there was a congressional mandate to form a committee to really take on autism and give it the attention that of course it needs and requires, just as ME/CFS does. We have minimal resources. We have, we could read this slide, and with the remaining short time I have, I'm going to have to go through these very quickly. I do hope that folks will look at them, and I hope that these will be made available to folks at home. So here we go. CFSAC does contain the puzzle pieces to make a significant difference for ME/CFS. So here, just as a reminder, we know this. Here are the federal agencies on CFSAC. We see at the bottom of the left-hand side, we do welcome new federal agencies because they help bring even more firepower to solving these problems. We have on the right federal agencies that are not yet on CFSAC, and I would propose that we should consider bringing them on. I understand there is a plan to bring on CMS, which would be very important. Then we have the non-federal pieces, patients and advocates, caregivers, et cetera. We're familiar with this list. And we need meaningful stakeholder engagement that brings each of these groups to the table. And certainly this is complex. And at the same time, it has been accomplished in other disease communities. So if we look at what this is very complex. So as the staff at SMCI and I have tried to pull this together, we've tried to give it some structure that made sense to us. And so if you look up across the top, you see leadership, and that is the core issue that is missing. And I don't mean, I am grateful for Karen Scott and for Sue and Gustavo and other leaders, but we don't have that overarching federal commitment and the leadership that comes with that. We also certainly have the research column, which can result in treatments and cures. The clinical care problem. We had a crisis in clinical care. I just imagine going, with a brain tumor to your doctor and your doctor turning you away. And of course that happens sometimes with brain tumors, but not for long because it grows and then eventually somebody says, and then there is care, there is empathy, there is sympathy, there is treatment, and there is hope. And with ME/CFS, that rarely exists. So clinical care, crisis, education and understanding, we've already touched on that this morning, but it's so critically important that doctors, even today, that both doctors who've been in practice a long time and doctors who are in medical school are not yet receiving the proper information about this disease. And then last is patient support. There's really almost no one doing significant patient support. Our organization is asked to do this time and again, and we simply don't have the resources to do it. So what I do next in these slides is take each of the areas. First, we have leadership. Fact, again, I'll state it. Since 2014, approximately 7% of CFSAC recommendations to the Secretary of HHS have been adopted and implemented. I don't know. I'm embarrassed and mortified by that fact. So the headline here is HHS must ensure ME/CF patients and research are a priority. And then you see below it three specific points that could move forward so that we achieve this agenda. And several of us were fortunate enough to meet with Karen DeSalvo, outgoing Assistant Secretary of Health, Karen DeSalvo, and I think she gets it. And it was thrilling, truly, to speak with someone at such a high level at HHS who clearly wanted to make an effort, and at the same time, I think she's got one more week in office. And the uncertainty there is very uncertain. So just to continue, still on HHS, Assistant Secretary for Planning and Evaluation. Again, there are 4 specific points which, if implemented, could really rocket forward the work on this disease. And again, this takes a change in many underlying assumptions about the power and the need for and the prioritization of CFSAC. Still on, now we are to us, to CFSAC, all of us. We must work with each agency to ensure ME/CFS-related actions and activities are being carried out. You know, we had been at a point forever where, you know, the recommendations would be made, the recommendations would be turned down, and that was the end of it. Our organization last year, for the first time, offered up a very simplistic way to look at that. We did a report card. We gave A, B, C, D, E, F on our sense of how responsive the agency's specific action had been to that need in the ME/CFS community. And at least it was one way to express back to agencies where we felt that we'd really get heard and that good work had occurred, and also where it had not been. But there are some procedural issues here, both, and I've divided them into 2 categories: the administration transition, and then new agencies that should be involved. And again, obviously, this all requires much more discussion. Okay, now we move on to NIH, and again, I would say a huge shout out of thanks to Vicki Whittemore, who I feel is a phenomenal advocate on CFSAC and for our disease within a very complex and difficult agency, which, you know, as of today, to my knowledge, doesn't know who their director will be, you know, next month, and that causes all kinds of difficult tensions. But we have comments here for the Office of the Director, currently Francis Collins, and then we have some comments here for the Trans NIH ME/CFS Working Group. And again, I skipped over the fact at the top. If ME/CFS were funded like other diseases of similar prevalence and severity, it would receive $250 million annually in funding from the NIH. Actually, Mary Dimmick, Dr. Jason, and others have done new, really rigorous analysis of the burden of the disease and come up with a figure that is lower than $250,000. It's $188,000. That really would only begin to bring this disease, as measured by the DALY, into parity with other diseases of similar severity. Again, at NIH must invest in the ME/CFS research ecosystem. There are clinical trials occurring, and that is certainly a good thing. And yet, we have not yet seen protocols, and there are some concerns among the community there. Let me move on to DoD and VA. Again, welcome. We are thrilled to have you here. As we know, the symptoms and the presentation of Gulf War illness is just highly overlapped with ME/CFS, and therefore we hope that that's a way that both diseases can benefit from the knowledge and the research from each of the others. So we ask DoD and VA to prioritize ME/CFS in existing education and patient care programs, and then you see some more information there about Gulf War illness, medical education, and patient support. Now moving to clinical care and education, we see AHRQ and HRSA. Fact, less than a third of medical schools include ME/CFS specific information in the curriculum, and only 40% of medical schools include ME/CFS. And we all have had the experience. I had this experience personally as a patient literally 2 years ago of trying to talk to my own physician about my disease, and literally got the eye roll. Didn't believe it was real. So we have seen, and I brought an example today of output from Harissa that is, and again, I am sorry to, I don't mean to offend anyone here, but it is offensive. It is so misguided in describing this disease. And it goes back to that concept of nothing about us without us. There are so many patients and patient experts and clinicians who could easily support our ex officio brothers and sisters in moving forward with information that would be useful and helpful. I know I'm short on time here, and now we come to the CDC. Again, thank you for the work that you have done. Deep concern that graded exercise therapy continues on the CDC website. And I know you've probably heard that more times than you need to hear it, but I gotta say it once again. It's just like a knife in our hearts. It's like, because we believe that it is so dangerous. And as you know, people go to the CDC for information, all sorts of people, patients, physicians, other agencies, and that is a deep concern. Other issues too, and again, nothing about it with us without it. We really, and the patient engagement group will talk more about what healthy patient engagement looks like in other disease communities, where it's not just one way. It is wonderful that you're soliciting information from patients and medical researchers, but it really ought to be most effective for everyone's benefit, a two-way street, so that information flows both ways. Let me continue here. More information about CDC here. FDA, thank you for your presentation. As we know, there are no approved treatments. Ampligen was approved in Brazil, and it sounds to me as though there are being changes are made at FDA that may begin to accelerate treatments for desperately ill ME/CFS patients who, when they can find someone who will work with them and prescribe these drugs, they are paying extraordinary prices because their insurance won't cover it because it's not an approved drug for ME/CFS. On to SSA. Again, thank you, Michelle. I think clearly you're beginning to support ME/CFS, but there is so much yet to be done. And I literally, one of the pains and joys of my job is the phone calls I get from patients that bring me to tears regularly, of people who have become homeless because they can't get support, they can't work anymore, and then from the folks who's the widows and the sons of individuals who have taken their lives. Those are very hard phone calls to take, and I feel as though I should record them and play them here. So again, I've completed the majority of what I wanted to state without any opportunity for discussion, and I wish we had more time for discussion. But again, the leadership, the research, the clinical care, the education and understanding, the patient support, all really need significant change. These pieces can work together, and I think a core issue here is an ME/CFS interagency task force. This would have to be done at the highest level. It has been done in other diseases. This is not impossible. It is absolutely doable. So I put forward one approach. I think this is a rational approach. I acknowledge that it may be radical. I acknowledge that it may be disruptive. And I don't take joy in that, but something has to give and significantly change so that ME/CFS patients are treated as they should be. I will say everything here is rational and grounded in knowledge, as is all our work at SMCI, our organization. We are fundamentally a research organization. People forget this because I stand up and make speeches like this, but we are a research organization. So we base all our work, whether it be research or advocacy, in fact, and that's just part of our organizational DNA. CFSAC can and should be a resource, and we can be active partners. It saddens me that we don't have more interaction between these two meetings. I will stand up and say, I will particularly for those of you who are new on CFSAC, I would welcome a phone call or an email. Hey, I was thinking about this. We're not sure about this. Can you help? Our answer will always be yes. And I think, you know, it's extraordinary for those of you who don't live and breathe every single day in the MECFS field the way we do. Do we all get that Dr. Jose Montoya is giving up 2 days of his life to come here? This is a preeminent, honored, distinguished, full professor at Stanford University with extraordinary knowledge. Sue Levine, who is one of the preeminent, most knowledgeable individuals, and I could go on and on. The resources in this room are extraordinary and have not been used. And if anyone on, you know, CFSAC was saying, no, I don't want to take those calls and emails, let me know. But my guess is that we want to do everything we can to support those of you who are ex officios. And I also sort of laugh. I feel as though maybe some of the ex officios feel like it drew the short straw. You know, oh God, you know, I'm on this CFSAC. And you may or may not feel that way, but I will tell you that you have an opportunity working with us to make a significant change in the world. How many times it's like, you know, you're the person standing outside the burning building and you either decide to rush in and save the children or not. Those opportunities to make a difference in the world don't come along often, but this is one of them. This committee, all of us together, are really the only entity in the country who can do that. And I am not a youngster, and I've been through a lot of committees and a lot of social change, and I recognize that this will not be easy. And it's not only because this disease is complex, and because the inertia about this disease is so heavy. In each of your agencies, there's inertia. In the public perception of this disease, there's inertia.
Excuse me, Carol, one more minute. We have public comments coming up. Thank you.
Okay. Well, I literally have 30 more seconds. There's inertia, and this will be difficult. I do believe that if we make some procedural changes to this committee, we can transition it from minimally effective, a 7% success rate, to a vibrant committee that drives change. There's no other body in our country that can do that. I trust that this next day and a half will be vibrant discussion, collegial, candid, thoughtful, and fascinating as we work on this urgent health crisis. I do thank you for the honor of working with you, and I am very grateful for the time, and I look onward. We can do this.
Thank you for a very thoughtful discussion. You clearly thought about this a lot and worked very hard.
Very inspirational.
Thank you.
Thank you.
Thanks very much. I'd like to acknowledge Dr. Gary Kaplan.